I also went through and highlighted a few other issues that I thought were important. First and foremost, when you talk about Medicaid expansion, our GDP is increasing at about a rate of 2 to 3%. Medicaid's increasing in costs at the rate of about 8%. So you do the math on when it's going to catch up to us. This is nothing but a bait and switch by the federal government, taking their liability off of their books and putting it onto the states. And I don't know about you, but I've worked too dang hard on the state to get our fiscal house in order to screw it up with this expansion of Medicaid. And it may not happen while I'm in office here, but it's going to affect your kids and our grandkids and nephews and nieces, and I'm not going to do that to anybody. There's minimum consequence for any rejection of the waivers that are actually in here. So part of the 4714 assumes that the federal government's going to give them a waiver so that they can limit the time that these people are on the Medicaid expansion to 48 months. The federal government's never going to do that. And by the way, we're never going to go off and rescind it after 48 months. Once you've gotten your equivalent to crack cocaine, you're never going to get them broken off of that, right? It's like the first one's free, kid, and then the next one's going to cost you. Once people are on that, they're not going to switch over. This also backdoor health exchange. Remember all the times we said no to that? Well, there's provisions in there that would essentially, the way I read the legislation, would allow the Department of Community Health to actually go off and implement a health exchange. They state savings calculations. They figure out what the formula is to determine the savings a year after it's actually implemented. Well, if you're so gung-ho that this is going to provide some savings, do it up front. Why wait a year to figure out what the formula is? Because then you can go off and reverse engineer the formula to the results that you want. A bunch of other stuff. It's really an experiment, and they admit as much with all the reports in here that it's an experiment to address something that's a big problem in healthcare costs, and that's cost shifting. And just so you know what cost shifting is, everybody that goes into an ER hospitals have to take people if they go to the ER, whether they can pay or not. So you can get free care there. Well, the hospitals respond by jacking up the premiums for everybody here, and the estimate's around $1,200 a year of our premiums actually go to pay for this uncompensated care. Well, they try to address this as a solution to that cost shifting. I don't see how it actually helps that at all, frankly. But it's an experiment, and they're putting a lot of extra reporting on there that kind of indicates that that's a fact. And the bottom line, too, is it increases government control at the expense of personal liberty. So what I've been trying to do is shape the battlefield a little bit and say, guys, when we're looking at a new healthcare system, I want to go beyond the stated objectives of Obamacare, and I want to add a few more things on there. I want to sit there and say, hey, does it lower our debt risk as a state? Does it go off and does it attract Michigan jobs or jobs to Michigan? Does it make us competitive with all the other states that are around here? Because jobs are created on the basis of total cost to an employer. If they can lower costs, that means they can hire more employees and become more effective and more efficient, more competitive in the economy. And so I want to add those into the equation. So what I'm going to talk about quickly here is the idea of a patient-centered care solution. And in this solution, we're pushing free market principles. Essentially what I'm trying to do is shoehorn a free market alternative into the Affordable Care Act. And there's some areas there that I'd love to push back on the Affordable Care Act and say we don't want to do it. And I'm going to take a shot at pushing for waivers in that area here. But the bottom line is we do have to work within some of the constraints that are provided with the Affordable Care Act. So my goal here is to provide the infrastructure necessary whereby all health insurance plans could be provided via privately administered qualified health plans. So I want the government out of the health plan business, health plan management business as much as possible. And the key feature of this, which does not require a waiver, because one of the people apparently forgot to read the bill before they passed it up in the Affordable Care Act, because if they would have known about this, they wouldn't have let it go through. But in section 10,104 of the Affordable Care Act, which is probably why nobody talks about it too much, it allows something called direct primary care services. Direct primary care services gets to what Dr. Janda was talking about, where I don't have to worry about an insurance company. I can do fee-for-service arrangements with the doctor. And this opens the door to significant cost reductions and significant increases in quality of care. So what you can do is you still have to comply with the national mandate. You have to comply with Kathleen Sebelius's definition of a minimum essential health benefit. But But now you can do so in a way that doesn't necessarily require an insurance company to be in the middle of it or the government to be in the middle of the definition of that plan. Now, I'm going to highlight some other reduction options later, and part of those reduction options include getting rid of that mandate. But I'm going to try to play within the sandbox that I've been given right now as much as possible. And if I can develop a quality health plan that features this, what I call direct primary care services or concierge service, coupled with high deductible health plans, you know, insurance used to be just about risk management. It wasn't about benefits management. Somewhere over time, you know, I think you were talking about 1965, or I was listening on the radio earlier today, or in 1965, all of a sudden the percentage of our income every year that were taken up by healthcare costs have been skyrocketing. Well, part of this is due to the fact that we've gone beyond, hey guys, I had a heart attack, I got cancer, I got something really bad happen to me, I need insurance because there's some bad things that can happen and it's going to be very expensive when it happens, to including everything, including doctor visits into there, including our prescription coverage, including everything but the kitchen sink into those benefits now. So that drives up the costs when that happens. Well now, if 60 to 75%, well, we're going to get into that in a little bit, 60 to 75% of your costs around healthcare deal with primary care services. So that's the stuff that's not the catastrophic stuff, right? That's the stuff where I go in and I get my lollipop and I go home with my allergy shot or whatever the case may be and say, right? I get my physical done, that kind of stuff. 60 to 75% of the costs are there. So if you focus on squeezing out the costs associated with that element alone, you've got some serious opportunity for some cost reductions. All right, so another aspect of my plan is let's migrate the existing Medicaid population to these high deductible health plan and DPCS qualified health plans. Now I just want to give you guys, for purpose of a backdrop here, and what the opportunity is when you start doing this. Right now, for that Medicaid population we were talking about expanding Medicaid for, the cost to the government right now, i.e. to you and me, is $5,000 per person, roughly. I can get a high deductible plan with a concierge service or one of these direct primary care services which provides unlimited access to a physician for $2,400 a year. So $5,000 down to $2,400, that's a significant cost savings opportunity, right? It's over 50%. Our DCH budget right now, our Department of Community Health budget is $15 billion. It's our largest budget line item in the state budget. What if we could get that cut by about 50%? What if we could take $7 billion out of that? You know, there's $2.8 billion in general fund dollars that go into our DCH budget. What if we could free up a portion of that maybe for some things like roads or something like that? Right? This is about making government leaner, smarter, more efficient. Well, if we start looking at this and how we're actually spending the money, that's the opportunity we're talking about. So if we migrate our existing population to this type of health plan, we've got an opportunity for some significant savings. And oh, by the way, if the federal government rejects our appeal to go off and do this conversion, you know what, we're right in the margin here of saying, okay, federal government, well, we're gonna cover these people anyway, and we're not gonna take any of the federal dollars, and there still won't be any incremental cost to the state of Michigan. Because remember I said it was a 40-60 split? If you can cut 60% of the costs, well, we're still paying that 40% here. So without any increased cost by the state of Michigan, we could say, yeah, thanks federal government, we don't really need your Medicaid. We got our own system here and we like it and it's working pretty well for us. We'll take care of the same population we were doing before without your help. Imagine if every state in the nation did that. That's pretty powerful. So I just want to let that sink in for a sec. Now, we talked about that it's if you migrate them to a high deductible plan, you got a high deductible, right? Well, the idea is we can set up a low-income trust fund for those people to then invoke their deductible. Part of the savings when you do this conversion is you can put it in this trust fund and cover what they call gap insurance. So if somebody does need to invoke their deductible because they got something bad happens to them in this current Medicaid population, we've got this fund that can cover the gap in their deductible. The other aspect of this is that instead of an exchange, I want to deploy what I call a government assistance portal. And this is not an exchange. This is limiting the scope of government to just determine whether or not an enrollee is eligible for government assistance or not. They're not taking care of the transaction with the consumer in any way, shape, or form. Essentially, it puts the government genie in a bottle and says, guys, your role is inside this area. You can't play. You're not going to be talking to our customers. You're not going to be one presenting what the options are for their coverage or anything else. All you're tasked with is that we're going to take information from one or more private exchanges, i.e. what we kind of have today. If you go to BlueCrossBlueShield.com or you go to Aetna.com or anything else, we'll take information for you in a standard data schema, and we'll process it through our government engine to determine whether or not you're eligible for any government programs, which, by the way, we can reconcile against one another to see if there's any fraud involved where somebody's double dipping on different programs. And then spit back a coupon to the private exchange to deliver to their customer and saying, hey, guess what? You're eligible for 50% off on this plan that we offer in our exchange because you're Medicaid eligible. Something to that effect on it. And what it does is, now these Medicaid patients are not getting the stigma, the scarlet letter of Medicaid coverage on it. They're getting a private insurance plan that actually is going to provide good quality care. Dr. Janda talked about those 4 reports that highlight that Medicaid is not quality care, folks. Private insurance does provide quality care, though. And so now we're switching these patients that were in this lousy care called Medicaid into a private insurance, and the interface is with private entities, private industry, private sector. So this is what we're trying to push, and you can put it inside of an HSA wrapper, so now you've got the power of tax-exempt status. For a lot of folks in the low-income area, that's really not a big deal for them yet, but it's an incentive when they get to the point where they are worried about paying taxes again, hopefully. Then they've got a built-in nest egg that's going to be accruing. And then one of the key principles of this is that I want to decouple government assistance from specific health plans. Wouldn't it be nice if they just went shopping out for qualified health plans, and there's some that they can afford, some that they can't afford based on their government assistance, but that government assistance is decoupled from the plan. So they actually get to tune that to the individual, not this one-size-fits-all Soviet-styled healthcare system. So the fundamental difference we're talking about is that Obamacare and all of its costs come into our little diagram there on the left. When you go over into patient-centered care, now you're doing cash transactions, credit card transactions with the physician. The physician spends more time with the patient, less time or no time worrying about coding for insurance purposes. I've talked to, how many of you guys saw the Huckabee a few weekends ago where they had the 3 doctors up there talking about this type of arrangement? There's a Dr. Nunemaker out in Wichita, Kansas, and a Dr. Zwelling, and a few others. Well, I contacted those folks and actually called them to go off and get how is it actually working in your state, in your practice. And a lot of the data that I have here that is fed into these bills came from my discussions with these people. It works, it's real, and it's going to be good for Michigan. So I want to highlight that here's a case where, and look it up, here, go off to Atlas MD. You can go out, the folks in Wichita, Kansas. I talked to this young entrepreneur doctor that I asked him how he got interested in this in the first place, and he said he was working for a surgeon and in residency, and that when that surgeon got out of residency and went out on his own, he found out that he was actually bringing home less money than when he was a resident. And he was working harder, but he was taking home less money, and he swore to himself that he was not going to be in that same ballpark. And so he went off and systematically analyzed where are all the costs that are in the system, and he found a way to go off and squeeze those costs out of the system. And when you start doing a cash-only business back the way medicine used to be, he found out that he can get most of those costs out. So I'm here to tell you this works. He has plans, and this is where free market comes in. You can vary the different types of plans. His plan in Atlas MD was based on age. If you're between 20 and 45, I think it is, or something like that, it's $75 a year. If you're a senior, it's like $100, not a year, $75 per month. It's $100 per month if you're a senior. It's something like $10 a month if you're a kid, and then he has a friends and family plan. The one under here, Epiphany, that you might see up there as well, is a Florida-based plan, same model. They have a different type of approach where they'll go off and do a friends and family discount, and they'll go off and aggregate it and give a bundle plan just like you would get for multiple services for your cable TV provider, right? So free market's pretty innovative that way. There's a lot of options that get opened up where you can get better service and better care for less money. I went off and did, just to make sure that I could do a sanity check, I went off and reviewed private health exchanges, put in bids to this. And I went to 2 different private exchanges, and within 30 minutes, I had people hounding on me saying, yeah, you want a quote, you want a quote, you want a quote, you want a quote? And I guarantee if it was a government, it would be a month from now before I'd be hearing back from these guys. And I found out that the prices were for between $96 a month and $206 a month for a high deductible health plan that provided good quality catastrophic coverage. So the two of them coupled together is less than $2,400 a year. I got a good quality plan that I validated and say, this is something we can do. It's already working. This is not pie in the sky. Now, to be fair, we only have a couple businesses that are operating as direct primary care services here in the state of Michigan. But if I had to race between deploying a business model that got rid of the government and one that's trying to implement the 20,000 pages of Obamacare, I'm going to take the free market model any day in that race. And it just takes focus and it just takes the energy behind it, and that's what we're working on. You're seeing the start of that movement tonight right here. And just for grins and giggles here, our folks out in Detroit are struggling with making ends meet right now, right? Well, they're talking about one of the big cost savings is to take all the employees and the retirees in Detroit and putting them onto Obamacare, right? Well, what if instead we put them onto this direct primary care service with the high deductible health plan, and we could cut their expenses by about half? That equates to about $136 million for the city of Detroit. And it might lower their overall health care liability from $5 billion in half to about $2.5 billion. So I've contacted Kevin Orr about this. I've contacted members of the Detroit Retired Police and Firefighter Association, and I've contacted a Democratic state rep to go off and promote this here inside the city of Detroit. So they've got this information. They're going to start rolling it out as well. There's other opportunities we'll get into later on. They're like certificate. This is just providing the framework. Once we've got people believing in the free market again and believing and knowing that it can work, there's other areas that we can do to gradually whittle away government and get it out of the middle, get higher quality care and lower our costs, like certificate of need repeal. How many people know what certificate of need is? Certificate of need is supply side economics implemented by our state. It actually controls the number of hospital beds, number of MRI machines that we can have in the state in a given region. I mean, you guys, I never knew about this before I got into office. I thought we were a free market healthcare system. Wrong. So we got to go off, and Dr. Janda approached me turned me on to this a while back, where he had patients that, if they're an HSA patient paying out of the pocket, they would, it would cost, in Michigan, because of certificate of need, it would cost $1,500 for an MRI. Ohio doesn't have a certificate of need, it's $250, I think it was. So to give you an idea of what opportunities there, huge. The idea of national insurance policy, data standardization, we talk about the Commerce Clause in the U.S. Constitution. Well, something that they really could do at the federal government to help is to standardize the flow of information back and forth like you do on a credit card application, right? Loser pays tort reform. We're the only country in the world that doesn't have loser pays, in the civilized world at least. And eliminate or reform some of these national coverage mandates and allow the opportunity for catastrophic care only instead of making sure that men get maternity coverage, that kind of stuff. And that's in there, by the way. It's in the Affordable Care Act. And then also the state of Michigan also has mandates as well. So that's kind of a primer on healthcare in the state of Michigan. I want you to understand that there's a lot going on right now in healthcare that's going to affect us for generations to come. And fundamentally, everything that's been involved, all the legislation that I've seen to date, is more about providing government control than it is about providing care. And it's about time we started getting we the people back into the equation. It means everybody here has to get spun up on this as well as me on it. I got to tell you, the reason we fought back all those initiatives on the health exchange and Medicaid expansion, and we put that into a stall pattern right now, is because of all of you. I'm one senator out of 38. But because you guys are vocal, because you're talking to people, because you're networking, because we're getting together with other people that are digging in and actually reading these bills now for the first time, we're making a difference. So we need to keep that up, folks. We need to get more educated on this stuff. And I tell you, I'm confident that we can carry the day and get back into free market healthcare systems that are going to benefit everybody and make our economy here in Michigan boom like it's never boomed before. Thank you guys all for your time.